Hi everyone, Dave Bosch again for part 3 of the Rush exam. Today we're talking about the pipes. Today we're going to talk about the AAA exam and the DVT exam. We're going to put all of the parts of the Rush exam together, and starting off we're going to do some spaced repetition and talk about the pump and the tank. We're going to start usually the Rush exam with an echo looking for pericardial effusion. We're going to look at left heart ejection fraction either by global estimation or by EPSS. We're going to look at the right heart and look for strain, and then we're going to look at the IVC and do an EFAST. Those parts can be done very quickly, and then you can move on to the pipes if you have not yet found the source of your hypotension. I want to talk through a case of a 77-year-old male brought in by ambulance for syncope. He had described just some lightheadedness and shortness of breath, but no other symptoms. No illness or recent travel, no vomiting, volume loss. He had a history of stage 4 kidney disease, hypertension, and prostate cancer. And he was hypotensive, afebrile, a little bit tachycardic, a little bit tachypnic, and hypoxic. And he looked a bit distressed, a little tachypnic, 3 to 4 word sentences, but had clear lungs, no lower extremity edema. His EKG showed sinus tach. And we had bedside labs at the time that showed electrolytes that were normal, but BUN of 75 and a creatinine of 3.8. So this is another patient who's undifferentiated sepsis or hypotension. Certainly have my suspicion of what was going on based on his presentation, but based on his creatinine, I knew I was going to be limited on being able to get certain diagnostics, so I went with ultrasound. Leaving the case aside for a second, we're going to talk about the aorta. Most of us should be comfortable doing an aorta study. This image on the left is what's typically shown as like a normal transverse picture of the aorta, the IVC, and posterior to that, the vertebral body. Just a reminder, when you're looking at the aorta, most aneurysms are infrarenal, and they're fairly large in size. A 3 centimeter aorta is normal, or less than 3. And after that, after you get over 3 centimeters, it becomes a lot easier to see, and you really start risking rupture around over 5.5 centimeters, upwards of 7 centimeters. So when you're looking for an aorta, and that's in your differential, if you're having trouble finding it because it's too small, AAA rupture is probably not the answer for your hypotension. These are 2 examples of very large aortas, both that have thrombus circumferentially around the still patent aortic vessel, and so you can see how they are very large. They come into view quite easily, and sometimes you lose sight of this in some bowel gas, but and they can be somewhat short. So it is important when you're looking to scan all the way down through the abdomen, and if you do that and you don't see any large vessel, then you can likely move on. After this, I will typically use ultrasound to scan for DVT, and this is a fairly quick DVT exam. I'm going to be doing both sides, and we're going to switch over to the linear probe. And we're just going to look in 3 spots. Most commonly, we're going to just start high up in the femorals, right where the saphenous vein takeoff starts. You're going to look at the common femoral. You're going to look at it's called the superficial femoral, which is kind of mid-thigh, and then at the popliteal vein. If you do that both sides, you can do that fairly quickly with a compression test, and it's got really good stats for both sensitivity and specificity. But this is, again, not a complete diagnostic study. In a rush exam, this is more to be used as a quick evaluation to look and rule in DVT rather than a comprehensive study to rule it out definitively. So this is what it looks like in the left common femoral, up high in the inguinal crease. The image on the right shows both the femoral artery and the femoral vein. With slight compression, you see the vein disappears, which would be consistent with normal anatomy. In the next slide, you'd see that with compression, you still have the artery. You've got an echogenic type structure within the vein, which is thrombus, and it does not compress. And I'd urge you, if you have any discomfort identifying thrombus on ultrasound, As you are ordering DVT studies on patients and get positives, I would urge you to actually pull those images up, look at them, and see what they look like when the ultrasonographers are doing their studies to get more comfortable with how thrombus looks in the veins. So that's it for the pipes. Back to my case, I did a rush exam that was somewhat modified based on what I was thinking. I jumped straight into like an IBC exam to look at his volume status, and then I did lower extremity DVT scan because I had a pretty high suspicion this guy had a PE. He had bilateral DVTs in his femoral veins, so that pretty much cinched the diagnosis for me. I started on heparin and got a hold of IR. At this hospital, they were interested in doing catheter-directed lysis, which they did. Fortunately, his vitals improved with fluid, so we didn't have to give him systemic thrombolytics. Later, his ED echo did show dilated RV, which again confirmed even more that this was likely PE, given that we couldn't get a CT. He was admitted to the ICU very quickly, actually, which is another nice thing when you have diagnostics like this. You don't have to wait hours on end to get a consultative ultrasound or VQ scans, whatever else you're looking for. And so this can help your flow. So that's it. Putting the rush exam all together is kind of the most important thing after you get all the different pieces. I typically don't do this the same time every time. I think it is really nice to use it based on really your gut and what your clinical examination starts you down, which path starts you down. But overall, my experience has led me to really start almost every time with an echo. And quickly followed by an IVC exam. I think that gives you really a lot of useful information about what the patient's volume status is, what their heart capabilities are. After that, using the ultrasound to look for an EFAS type exam with lung, and then followed that by DVT. And really lastly, I do aorta, because if you haven't found a AAA by the time you've completed an EFAS exam, it's really unlikely. So the AAA exam tends to come last. And if we go through this in the different shock types, we can talk about how this will look in each part of the rush eval. So if we start with maybe the most common type of shock, or hypovolemic shock, we look at the pump, and we're obviously going to see a hypercontractile tachycardic heart with very small chambers. The IVC will be flat. And if you end up looking in the belly, and you may see an abdominal aortic rupture with a positive FAST. Contrast that to cardiogenic shock, which when you look at the heart would be a very dilated hypocontractile heart with likely a distended IVC. And in a cardiogenic picture, your pipes or examination is going to be normal. Obstructive shock, we're going to see again hypercontractile. Maybe a pericardial tamponade type picture with an effusion, or RV strain. These are all types of obstructive type shock. You may see a distended IVC because of the high intracardiac pressures. And if you see an absent lung sliding, you may have a tension pneumothorax. And then if you get down to the pipe eval, you may see a DVT. And then last but not least, distributive shock. So this is our sepsis type shock. We're going to be looking at a hypercontractile heart with either normal or small IVC with a normal pipe exam with no evidence of a DVT or AAA. And so those 3 types or 4 types of shock are how we classify things in the rush exam. I think after you do each part, you again will start to modify this and maybe not use every piece of the rush exam on every patient. But if you get to the point where in any patient who's hypotensive, you bring the ultrasound to the bedside and start looking, I think this type of examination will really guide you and help you get moving on the right diagnosis right from the get-go when you see a patient. Thanks, guys, for tuning in to the last 3 parts. Hope this was useful.